Hello and welcome. This is Health Promotion Practices author interviews, and my name is Arden Castle. Each episode will explore a recently published article and its author. This week, I am joined by Dr. Carlos Mahaffey, author of Evaluating the Feasibility of Implementing an HIV Prevention Intervention for Incarcerated African American Men, Lessons Learned from a Pilot Study, which was published in September 2020. This episode is focused on the findings of his paper, which is just one part of a three-part series with Dr. Carlos Mahaffey. Tune into our other episodes to hear more about him and our other authors. So, congratulations, you have recently published an article in Health Promotion Practice Journal, which was published in September 2020. For those of us who are not as familiar with the article, can you give us a 2-minute summary?
Sure. So the basic of this study was to take a successful HIV intervention program and make some revisions to it and adapt it to deliver into a minimum security prison for men who are soon to be released back into the community. And so the original HIV intervention program was focused on reducing HIV risky behavior among male drug users. And so we applied that same logic to use for men who are incarcerated, who are also substance users. And so we made some revisions, as I said before, and delivered the intervention. I delivered it myself over the course of 3 sessions over several repeated times. And so we explored if we could deliver this HIV intervention, what changes or revisions we would have to make to the program itself, if we were able to deliver all of the components of the program, and how receptive would each of the men be for the program. And so we just, again, documented our interactions with the warden of the minimum security prison, also took notes and feedback from the men as they participated in the study, and also just their feedback after we completed the study. And so it was a pilot study in a sense, in a way to determine if we should make this larger or if we would need to go a different direction. And so that's the basis of it. And again, just documenting the limitations of being able to conduct such a study, even though we know that doing HIV intervention with men who are soon to be released is a great opportunity, because you have this population that's already together and they're eager to pick up on programs or participate in things like this just to prepare them as they are released.
Excellent. Thank you for that quick summary. You mentioned that you were working based off of an already created program. Can you give us a quick history of the Real Men Are Safe HIV intervention and its adaptations prior to this paper?
Right. So as you said, Real Men Are Safe, or REMAS, was a program created by Dr. Donald Callison and Dr. Kathy Burlew. And so they created this program for male substance users and delivered it, and it focused on a different behavior and skills and communication, and combined all these aspects in a way that would eventually reduce their HIV risky behavior. So the original REMAS was performed with mostly white males. And so after they were able to implement it and detect the success and behavior change, they decided to adapt it and created REMAS-CA, or Real Men Are Safe, Culturally Adapted. And in this version, they focused on Black and brown men, and they were able to make some cultural changes with some of the terminology used. And from there, they also were able to see those same successes. They wanted to focus basically all of those constructs, specifically with Black and brown men, and pulling in those cultural components.
And so when you implemented REMAS-CA, there were both expected and unexpected revisions that were required. Can you talk us through some of the more notable points that you found?
Absolutely. So we knew for sure that we would have to change some of the terminology. We wanted to incorporate terms, especially, for instance, thinking about drug names that were used amongst the population. And so we would use, say, Xanny or bars for Xanax, using Molly and terms like that, that the persons would be familiar with. So we knew we would have to do that. And then also we kind of had an expectation. So I was a postdoc at the time, and my mentor was the PI, Dr. Danielle Stevens Watkins, and she has a lot of experience with the justice involved population. And so she knew that we probably wouldn't be able to show one of the components of the program, which included scenes from films that focused on communication. And she had a pretty good idea that we wouldn't be able to show those films. And so, again, those are some of the expected changes we knew we would have to modify before we even introduced the program. Another expected change was we knew that we probably wouldn't be able to do the condom demonstration that's part of the program, just because it's well known that condoms cannot be brought into prisons, even if it's minimum security, because it's considered contraband if we bring it in as researchers and forget one or something like that. Then it's been said by wardens and by prison boards that prisoners could use it to transport drugs. And so that's another thing we kind of knew we wouldn't be able to include. Now, some of the unexpected changes that we had to make was that we, again, talked with the warden, and we had to completely remove a video that just talked about female condoms and how to use it. They said it was, basically unacceptable. They just didn't approve of it. They didn't give too much reasoning behind it. So we had to completely remove that video section, even though it was no physical condoms. And we actually, after that, kind of decided to just remove even the male condom component. Even though we weren't going to use the condoms, we decided not to even have that component just talking about it, because it might be confusing having to talk about how to put on a condom, but not even being able to have one there and physically show them, or show them on a video. Because if the video wasn't acceptable for the female condom, then also they weren't going to let us show a video for the male condom either. So that was one of the unexpected revisions that we had to make to the program.
It's interesting to hear how even with this culturally adapted piece that you were still having to make additional adaptations, and that there's not like a one size fits all for these kinds of programs. And it's interesting, some of the unexpected things that you were faced with. I'm curious, how does the influence of culture on health and behavior play out in your study population?
So it's very important, and we have a lot of examples of this, especially just considering the Black population in general. We had the Tuskegee syphilis experiment, where Black men were experimented on by the government, and in a very unprofessional, unscientific way, for several years. Even after there were treatments available, it wasn't given to them. They weren't told exactly the risk that would be involved. And so that has left a lasting impression on the Black community. And me being from Columbus, Georgia, Tuskegee is just 45 minutes away. And so I grew up knowing about the Tuskegee experiment from my father and from family members. And it was something that was just known amongst the Black community. And so it's always been understood that when it comes to research, that's one of the first things that the Black community thinks about. And so you really have to consider that part of our culture and the weariness that Black people have, no matter where we are, against actually participating in research. And so you have to take care to make sure that you're explaining what the risks are. Even though they tell us that we will have to do this on an informed consent, you still have to take that extra care to make sure that they understand that this is nothing that will harm you. We're just trying to get some information and make the community better with our findings from what we get, and make sure that they know that they are part of the research, that this is something that we're doing with them and not to them, as I stated earlier.
Definitely, that transparency and research. And even I want to pull out one part that you said about we're doing this for the community, that the findings that you are able to decipher at the end are going to be put right back into the community. You're not taking that information and applying it elsewhere and continuing to let these particular folks remain in the conditions that are not ideal for them.
Exactly. Mm-hmm.
In your paper, you state that an HIV prevention intervention such as REMAS-CA provides the opportunity for prisoners to receive testing and counseling for HIV and knowledge on how to reduce risk behaviors, critically important in states without explicit HIV testing laws. Can you help us unpack the implications of this finding? I know we've kind of just talked about them, but a little bit more about what this line meant in the paper.
So I think something that stood out after this experience is that we realized there is no type of overarching rules or regulations for how health is carried out in prisons. So the warden of that particular prison is in full control of how health is disseminated in that particular prison. So there's one difference in one prison to another prison. So no two prisons will be alike. It's really completely up to the warden to decide what their prisoners can and cannot receive. And so with that being stated, even though there may or may not be any state laws around HIV testing and counseling, often those laws will not be applied universally to prison populations. And so this program, if it is able to be implemented over several institutions, then it establishes a baseline that will follow the basics of what you should receive as any individual that's being given HIV testing and counseling that's associated with that testing. So again, just making that opportunity clear when there is no set basis or baseline of health that's required in a prison setting.
Definitely. I think that not only is there no overarching set of standards, like you said, but that there is also this individual variability at the warden level. And so thinking about how we can create opportunities, I definitely agree. That's exciting work.
Yes, yes, it is.
Well, that is all that we have for you today to talk about the paper. Thank you, Dr. Carlos Mahaffey, for joining us today, and thank you all for listening in. If you'd like to find out more about our guest this week, you can reach him here. And as always, follow us on Twitter, LinkedIn, and Facebook for more author interviews. Thank you.
Thank you.